All right, welcome back to Chapter 7, Mental Health in Alternate Care Systems. We are picking up on page 235 in the text with regulatory issues. So, mental health centers typically receive certification from a designated state regulatory agency, usually a department or office of mental health. These agencies establish licensure standards and perform monitoring functions accordingly. As mental health consumers and their family members have become increasingly politicized in recent years, the agencies have engaged in a steady effort to make the regulations for licensure more outcome-based. The thrust is more toward measuring quality of services than quantity or frequency of delivery. Another regulatory mechanism exists at the state level for both inpatient and outpatient facilities that wish to receive Medicaid. They must comply with the Medicaid guidelines set and monitored by the state agency designed as the regulatory body for this funding. Similarly, facilities that receive Medicare reimbursement must comply with the applicable conditions of participation. The conditions of participation for hospitals include special provisions applying to psychiatric hospitals in sections 482.60 and 482.62. including special medical records requirements for psychiatric hospitals. All right, flipping over. There's other regulatory entities set standards for mental health services delivery by virtue of their accrediting process. And we have a couple of these: the Joint Commission, CARF International, the National Committee for Quality Assurance, or NCQA, and URAC. They should sound familiar to you by now. The Joint Commission provides accreditation for inpatient and outpatient mental health facilities. A facility licensed as a hospital is surveyed under the Comprehensive Accreditation Manual for Hospitals. If the hospital offers residential treatment, partial hospitalization, or supervised living programs, the Joint Commission conducts a tailored survey using selected standards from the Comprehensive Accreditation Manual for Behavioral Health Care, in addition to the standards in the Comprehensive Accreditation Manual for Hospitals. CARF provides an accrediting process for mental health and psychosocial rehabilitation programs. Programs that can be accredited include case management, crisis intervention, outpatient treatment, partial hospitalization, residential treatment, community housing, inpatient treatment, assertive community treatment, and many other services. A mental health facility seeking accreditation from CARF would be surveyed under its Behavioral Health Standards Manual. NCQA offers an accreditation program to managed behavioral health care organizations. A managed behavioral health care organization may be a managed behavioral health care company or a behavioral health program or department within a managed care organization. At the request of an MCO or an MBHO, NCQA surveys mental health services under the MBHO standards and guidelines. Clinical services of MBHOs, too, are often accredited by URAC. URAC also accredits case management services. All right, so let's talk about documentation. Mental health case records are considerably similar, whether inpatient or outpatient, as are other medically oriented records. Although content and arrangement vary, certain information is basic to all treatment of individuals with mental illness and appears in some form in the mental health record. This includes assessment, treatment plan, progress notes, discharge summary, with plans for aftercare. So let's talk about the assessment over on 237. At the first contact between a consumer or patient and a mental health facility, an initial assessment is performed. This could occur in a telephone contact or in an emergency encounter. The initial assessment focuses on the patient's apparent needs and whether the facility can address those needs appropriately. In some instances, the result of the initial assessment is to refer the patient elsewhere for further services. If it is determined that a patient should be admitted to the original facility, the initial assessment serves as a basis for determining which services of the facility are most appropriate. A complete assessment may include any or all of the following: physical, emotional, behavioral, social, recreational, legal, vocational, and/or nutritional components. It should be noted that assessment is an ongoing process. Several interviews may be required for the consumer patient to gain sufficient trust to fully state the nature of his or her problems. All right, moving over to page 239 to continue on with treatment plans. Traditionally, the assessment process has been a procedure by which the interviewer or team evaluates the consumer patient's level of functioning. The problems have thus been defined essentially as deficits in functioning that should be addressed in the treatment plan, with steps to mitigate or eliminate the problem outlined. As consumers have embraced the notion of empowerment, however, they have become more insistent on participating in the treatment planning process. Particularly in the outpatient setting, consumers have complained that the established method placed them in a position of inferiority in a relationship to the interviewer, and often resulted in a treatment plan in which they had little interest and no investiture. To expedite and encourage the consumer's participation, a strengths model of treatment planning has emerged in the community mental health sector. Using this approach, the interviewer determines from the consumer what goals he or she is interested in pursuing. The interviewer and the consumer then work out a mutual plan to achieve that goal. All right, flipping over to page 240 to continue on with progress notes. Progress notes mark the achievement or lack thereof in attempts of the consumer or patient to reach the goals stated in the treatment plan. Accreditation surveyors often check to see that every goal in a treatment plan has corresponding progress notes. Although some general progress notes do not relate to a specific treatment plan goal, most progress notes are tied directly to the treatment plan. Progress notes are essential as documentation that a service was performed as a basis for reimbursement from Medicaid, Medicare, or client insurance. If it isn't written, it didn't happen. As a basis for reimbursement, the timeliness of the note also becomes a central issue because most regulatory agencies place considerable emphasis on regular intervals of review and updates of the treatment plan, which are also usually recorded in the progress notes. All right, flipping over to page 242 under special procedures. Some procedures may be necessary in the mental health setting that may not be used in the treatment of other types of disorders. For example, a patient who is threatening injury to self or to others may be placed in restraints or in seclusion. Examples of other types of special procedures include psychosurgery and electroconvulsive therapy. When special procedures are used, proper documentation of their use is essential. All right, dropping down to the bottom of that page, we're going to define restraints really quick. So we got two types of restraints. We're going to talk about physical restraints first. So physical restraints are described as mechanical or personal restriction that immobilizes or reduces the ability of an individual to move his or her arms, legs, or head freely, not including devices, for the purpose of conducting routine physical examinations or tests, or to protect the resident from falling out of bed, or to permit the resident to participate in activities without the risk of physical harm to the resident. So physical restraints are just like they sound. They're physically holding you down to the bed. You're strapped to the bed. Then you have chemical restraints. So in the Children's Health Act of 2000, chemical restraint is defined as the use of a drug or medication not part of the person's usual medical regimen that is administered to control behavior or restrict freedom of movement. The rules for applying restraint or seclusion require an order from a board-certified psychiatrist or a physician with specialized training and experience in diagnosis and treatment of mental disorders. Assessing the need for such procedures must include consideration of all possible alternatives and a rationale for the chosen intervention. At its core, the issue must be safety of the patient. All right, and we're going to go over now to discharge summary and aftercare plans on 244. The discharge summary contains the reason for discharge, noting whether the person left in a timely manner or against program advice, and if the person is living in the community. Hospital discharge in the case of an involuntary commitment has to include the doctor's order certifying that the person is no longer a danger to self or others and therefore is ready for discharge. Although some hospitals have begun to determine that readiness for discharge is a decision of an interdisciplinary team, the treating physician has ultimate responsibility for discharge. Documentation related to discharge summaries Documentation related to discharge summarizes the goal of treatment plan and progress that has been made. It includes linkages with the other programs, including mental health, to which the person has been referred, and any appointments that have been made, and a prognosis statement as to the future expectations of the person's physical and mental health. Other details documented in the discharge summary in a psychiatric hospital include the final diagnosis, medications and instructions, disabilities if any, dietary instructions, and with whom the patient was discharged. Although discharge summary documentation is necessary in both institutional and community settings, it is particularly important in a timely manner in the inpatient setting. Community programs often have policies that prohibit recently discharged patients from participating in their programming until they have received the hospital's inpatient discharge summary. All right, so reimbursement and funding at the bottom of 247. Again, we're going to hit the highlights for these. So the principal resources or principal sources of funding for the community mental health centers are client fees, Medicaid, Medicare, and block grant funding for special projects. Client fees are calculated on a sliding scale basis on income, and they account for a small percentage of the overall budget. The majority of the income for community health centers comes from Medicaid and Medicare reimbursement. Some funding comes from federal block grants, typically distributed through the state mental health agency to support special initiatives. All right, over on 248. In 2003, CMS published a proposed rule to create Inpatient Psychiatric Facility Prospective Payment System, or the IPF-PPS. This is for Medicare payments both to the freestanding psychiatric hospitals and to psychiatric units in acute care hospitals. The final rule was issued in 2004, and the new payment system took effect January 1, 2005. Under the Inpatient Psychiatric Facility Prospective Payment System, inpatient psychiatric facilities receive per diem payments that are adjusted up or down by 4 patient-level factors, and those 4 factors are the patient's age, so higher rates for patients 45 and older through 80 and above, and then a variable per diem adjustment. This is a higher per diem payment for the first day of the patient's stay and gradually decreasing through the 22nd day. And if they're there for longer than 22 days, there's no decrease beyond that point. So it will decrease up through the 22nd day of their stay. And then the Medicare Severity Diagnostic Related Group, or the MSDRG for the stay, and then also certain comorbidities. Only one comorbidity adjustment is made for each comorbidity category, but adjustments for more than one comorbidity category are possible. All right, we're going to move over to 249 with information management. Beginning in 1975, there was a movement toward creating a uniform, integrated statistical reporting system for mental health at the national level. In 1975, the Division of Biometry and Epidemiology proposed an undertaking to create such a system. As a result, the Mental Health Statistics Improvement Program became an early initiative within the National Institution of Mental Health to create a uniform data system nationwide for reporting mental health statistics. MHSIP suggested that the state mental health authorities work cooperatively with NIMH to create a broad-based data collection spearheaded by state efforts. And there are goals as follows. First one, enhance state, local, and national mental health agencies' capacity to respond to local, state, and national needs. Train sufficient systems and statistical personnel to collect, process, and analyze the data generated by these systems. Provide an ongoing cost-sharing mechanism for the production of data required by the federal system. An ad hoc advisory group, we're starting on 250, consisting of personnel from local, state, and federal programs, undertook the early work of establishing data sets that were widely accepted as the appropriate and useful. In 1984, the initiative received a second strong impetus with a mandate from Congress to create a system for data collection regarding mental health and substance abuse. Unlike the substance abuse system, in which the move toward uniformity was translated into a set of federally mandated standards for data collection, the mental health system chose to promote guidelines rather than specific standards. Thus, participation in the initiative continued to be voluntary. The congressional directive led NIMH to publish in the next year the Data Standards for Mental Health Decision Support Systems, or FN10. This manual became the basis for all subsequent work in the effort to create a compatible data reporting system. It had a significant impact on the direction and scope of current thinking about mental health data, as it made a strong case for the including more than just client service data. The case was made for expanding the data collection into areas such as finances and human resources as auxiliaries to the direct service area. All right, so again, be sure to read those sections. We're going to move over to 252 under Information Management and Data and Information Flow. Intake procedures vary within community mental health system. Because of staff constraints, few community mental health centers are able to take walk-ins except those in emergency situations, usually defined as persons in need of inpatient commitment because they are deemed dangerous to self or others. Typically, applications are received and screened as to the seriousness of the case, and the appointments are established, including an appointment with a psychiatrist if it is clear from the application that an appointment is needed for medication issues. Priority is given most often to persons who have been discharged from inpatient care. These appointments typically are set up by a social worker at the institution before the person's discharge. All right, be sure to read about these DIGs and the NOMs. You're going to see that when we get over in the coding and classification on 255. There's a variety of coding systems. We've talked about DSM-5 back in health records, and then we've already talked about it a little bit in this chapter. And then also you've got your ICD codes and your CPT and HCPCS codes that are used as appropriate. And then moving into those data sets, looking over at 257, you've got terminology related to mental health data sets. And then you've got information for each of those. So know that purple table or blue table on 257. And we're going to finish off with quality improvement and utilization management over on 258. The mental health field has been at least as susceptible as other segments of our society to the current focus on total quality management, or its more recent manifestation of continuous quality improvement. The focus of both these management techniques on customer satisfaction and sharing of decision-making power between administrative and line staff is a natural fit with the mental health consumer movement toward empowerment. These concepts have been, for the most part, well accepted by now, and in general incorporated into both the outpatient and the inpatient systems of care. Client-centered approaches permeate the mental health system, affecting all aspects of service delivery, from programming that encourages self-determination, emphasizing consumer strengths rather than functional deficits, to data collection that focuses on client satisfaction and feedback mechanisms. Performance improvement is an important component in the Joint Commission accreditation for inpatient facilities. Because this accreditation is generally accepted by major funding sources such as Medicare and Medicaid, it frequently is sought after by inpatient facilities. Over the years, utilization management has led to the downsizing of large public mental institutions. The move to deinstitutionalization, while resulting in part from the improvement of stabilization through medication, also has been driven in part by economic considerations. It has proved to be much less expensive, generally speaking, to maintain consumers in the community with a variety of support services than to keep them in the hospital, which is more costly medical orientation. All right, so moving over to risk management and legal issues on page 259. Risk management as an organized program exists more frequently in the inpatient treatment sector than in the outpatient treatment sector. The function of this program is to predict and thereby reduce or eliminate sources of likely injury and accident or of other potential financial losses to the institution. Such responsibility obviously includes avoiding litigation, which leads to the involvement in treatment issues that carry high risk of violating patients' rights, such as the use of restraints, informed consent regarding administration of medications, and timely discharge when stabilization has occurred. So let's talk about confidentiality in these records. So patient information in mental health settings has always been highly confidential. It was more restricted than other types of medical information until the passage of HIPAA, which tightened restrictions on all types of medical information and brought confidentiality more in line with practices already largely in place within mental health. For example, before HIPAA, in settings outside of mental health, information such as a patient's name and dates of service was considered non-confidential and could be disclosed in the absence of a specific request by the patient to prohibit the disclosure. In mental health facilities, however, this information traditionally has been legally protected. Even acknowledging that a patient was treated at a facility has been considered a breach of confidentiality. Mental health facilities always have placed great emphasis on strict confidentiality, and long before HIPAA generally required all employees and vendors to sign confidentiality agreements, prohibiting staff and vendors alike from disclosing any information regarding patients who had been treated at the facility. HIPAA provides more protection to psychotherapy notes than to other types of protected health information. The use or disclosure of psychotherapy notes requires valid authorization even for treatment, payment, and healthcare operations, with the following exceptions. The originator of the note may use them for continuing treatment. So if the physician wrote the note, they can continue to use the notes without an authorization. 2, students, trainees, or practitioners may use psychotherapy notes and supervise mental health training programs. 3, the covered entity may use the notes when necessary to defend itself in a legal action brought by the individual. And 4, notes may be used as needed for health oversight activities or other activities as required by law. Now, although we say that these records are extremely confidential, there is a duty to warn. And if you look at that definition on page 260, it's over in that left-hand margin. Duty to warn is a legal concept holding that mental health professionals have an obligation to issue a forewarning about a person whom a client with mental illness has threatened to harm, despite the usual protections of confidentiality in the client-professional relationship. So if you're a psychiatrist and you're talking to a patient and that patient tells you that they are going to kill their spouse, then you do not have to keep that confidential. That is what's called a duty to warn. And so that is the exception to the confidentiality rules in mental health. As if someone says, I'm going to harm this person on this day, or I'm going to kill them, or you have a duty to warn. And so you're not breaking any laws by sharing that information. All right, so let's talk about court-ordered treatment over on 261. One of the most tragic aspects of serious mental illness is that persons who are in the grips of psychosis are victims of disordered thinking, which prevents their recognizing that they are indeed ill. They often are unable to make decisions in their best interests, such as recognizing their need for psychotropic medication, and may be led by their delusions to acts that are dangerous to themselves or to others. In these cases, the mentally ill persons may need to be in court-ordered treatment. Treatment under court order generally is predicated by a procedure that is similar throughout the nation, with slight variations from state to state, and in some states even from country to country. Usually there is an examination of the person deemed in need of treatment by a physician and or medical health professional. The usual criterion for court-ordered commitment is an inpatient institution is the professional certification that the person is a danger to self and or others. So if a physician certifies that you are a danger to yourself or a danger to others, you can be committed, and that's what that involuntary commitment is, by a court. And you can't just walk out when you think you're done with treatment. You're stuck. All right, moving over to the last section, role of the health information management professional. Increased interest in technological advances in data management is expanding the potential role of health information managers in the field of mental health as in other areas of healthcare. The traditional role of the profession has been in the institutional sector of mental health services, where the chief responsibilities have been the recording, storing, and monitoring of patient information. Frequently, however, community health centers are finding that decision-making and management information systems is becoming increasingly complex and requires an expertise of its own. This area would seem to be a logical extension of the domain of the health information manager in the era of electronic information systems. Outside the domain of client data collection, another major potential for the expanding of the traditional role of the health information manager within the community mental health center is the area for reimbursement in the revenue cycle. Because of the multiple and disparate nature of the sources of funding for community health services, this is a complex arena for information storage and management. Health information managers also may assume roles in quality improvement and risk management, or they may work as consultants to mental health facilities. A health information management consultant can advise a mental health facility about issues related to accreditation, information management, or automation of patient information. A consultant assisting with the automation of patient information might have responsibilities ranging from helping write requests for proposals for new information systems to assisting with actual implementation of a new system. A health information manager who chooses a career in mental health can find opportunities for advancement within the field. Some have moved into positions of increased responsibility, such as oversight of all information systems. With additional education, HIM professionals with experience in the financial and administrative aspects of the mental health system have moved into other managerial positions, such as director of the Community Medical Health Center. Alright, so again, finish out this chapter by reading through the trends and the summary. Be sure to read the entire chapter, complete your quick check, and test yourself. And happy studying mental health.